So thank you so much, honestly, for taking time out of your busy schedules to hear about joint pain and what you can actually do about it. And I saw this interesting quotation, and I think it does apply here. Some people drink from the fountain of knowledge, others just gargle, and it was by Robert Anthony. And I hope we will be able to provide you with that fountain, and that this presentation will educate you on the latest technology and treatment options for joint pain. And now, just before we get started, could we have a show of hands as to how many people have joint pain or know somebody who does? Great. And as you can see, I'm including myself in this category. My mom's got really, really bad arthritis in her knees, so I actually know firsthand what it is like to have someone you care about go through joint pain, what treatments this person needs. So tonight we're going to actually talk more about knee pain, but honestly this does apply to other joints like the hip or the shoulder. And then so for this presentation we're going to cover things like what causes joint pain, what are your treatment options. We'll go into the Navio robotic system, which is the latest and greatest in technology for joint replacement. And then we'll talk about experience at the surgery center. And finally at the end we'll leave some time for questions and answers. Now, I saw this interesting statistic. 46% of people have osteoarthritis, and I mean, there are a lot of different causes for joint pain. One of the main causes is arthritis. Now, does everybody here actually know what arthritis is? What does that mean? And the reason I'm asking is that my mom, she has a PhD in industrial engineering. She has heard me talk about my job as an orthopedic surgeon for over 20 years now, and she's the one with severe arthritis. And just a few weeks ago, she actually asked me, Rena, what exactly is arthritis? So I thought, okay, well, clearly we throw this term around all the time, but do people actually know what it is? And someone who's as educated as my mother and well-read, she actually didn't really understand what it is. So arthritis affects joints. Well, what's a joint? A joint is hip, knee, shoulder, anywhere where you have two bone surfaces that move on each other. The ends of the bone are covered with something really, really super smooth called cartilage. And when that cartilage deteriorates or degrades, that's when you get arthritis. And really, that's all arthritis really is. And 46% of people, that is just a huge number. So it's way, way more common than we really think it is. Now, arthritis actually does progress over time. So the diagram on your left-hand side shows a knee, and what you're seeing is that whitish blue stuff, that's like really, really smooth cartilage. In the very early phase, it just starts to wear out just a little bit. Normally, it's about 1/4 of an inch thick, but in the early stages, it just starts to disappear. When you get to a later stage of arthritis, you really do start to see it completely worn out. You get these bumpy things. They're called bone spurs. This is what bone grinding on bone starts to look like. That's kind of getting in towards a milder stage, mid-stage arthritis. When you get to the worst end stage of arthritis, all that beautiful white cartilage is now totally broken down. It's now you have bone grinding on bone, and that's what it actually looks like, and that just really hurts a lot. Does that kind of make sense as to now what arthritis really means? So I'm going to show you some x-rays here. These are the x-rays of a healthy knee, right over here. So you've got bone, bone, and in between it looks like there's a big old empty space. It's actually not empty, it's filled with cartilage. The x-ray beam goes right through cartilage, so cartilage doesn't actually show up on the x-ray. So when you start to get arthritis in one part of the knee, that cartilage is gone. So now you're actually getting bone grinding on bone. You can see here there's still some cartilage left. And then over here, there is no cartilage left. This is bone on bone, and you get those bumpy things called bone spurs. I bet you this person, you could probably hear this person's knees grind as he or she would walk across, and that really is very painful. Okay. So what actually causes arthritis? Well, one of the most common causes is age. When we get older, our hair gets a little bit gray, our skin may develop some creases, and we're not allowed to say the word wrinkles, they're just creases, and our cartilage wears out. It can also happen if someone is like really, really active, like running, jumping, doing a lot of sports. Unfortunately, it can also happen when someone has a little bit of extra weight on the body. It's putting a lot more stress on those joints and wearing out the cartilage. And of course, if you fall down, hurt yourself, and damage the cartilage, it can really end up causing arthritis later on. And cartilage is just one of those components in the body that once it's gone, it's gone. Your body cannot make new cartilage. And it can also be genetic. If your mom or grandma or some other relatives had arthritis, chances are you're likely to get it as well. And I know my future, my mom's got arthritis, I am sure I'm going to get that too. So now, how do you know if you actually have arthritis? About 80% of people experience limitations in movement, so that means stiffness. You get pain, sometimes you get swelling. That's what arthritis actually feels like. It's like it's hard to walk, it's hard to go up and down stairs or basically do the things that you want to do. Even something like, you're at a public restroom trying to get up from a toilet, that becomes really hard. It's tough to like spring out of bed and tackle the day. That's when you know arthritis is really affecting you. So, what can we actually do about arthritis? And I'm a surgeon, I love doing surgery, I love my job, but surgery is not the first thing that I would ever prescribe or recommend. So we do have a lot of options to help alleviate knee pain. Just having knee pain or arthritis doesn't mean that you have to have knee surgery. And I'm going to show you some options that you can discuss with your own doctor that might help you with your knee pain. One of the best things that we can prescribe is exercise. I actually knew one doctor who would put on his prescription pad exercise, and he would hand it out to patients like a real bona fide prescription. Now, exercise doesn't cure arthritis. It can make the muscles stronger. It can take the pressure off the bone, so that's helpful, and that alleviates pain. And in conjunction with this, even a modest amount of weight loss can be very, very helpful. There's something called the 1 pound, 3 pound rule. This means that if you lose 1 pound of weight, your knee thinks it's lost 3 pounds. So if you lose 10 pounds, your body thinks it's lost 30 pounds. So even a small amount of weight loss for someone who's a little bit heavier can make a huge difference in pain relief. Now this leads to our next option, physical therapy. Some people just have a hard time doing exercises on their own, and this is where physical therapy can help. A physical therapist is a trained professional who can help people with mobility, strengthening, basically being able to walk and move around a lot better. I put this slide in here about bracing, and this is an example of a knee brace. It's a device that you put on your leg and has these dials. In my experience over the last 20 years or so, I find that a lot of patients find them to be clunky and cumbersome, and these just end up sitting in the back of someone's closet. Some of them can be very expensive. It depends which brand you get. If it's custom made, they can be $1,500 to $1,800. So is it worth it? Some people say yes, other people say no. So if a patient wants it, we can certainly explore that option, explore it with the insurance, but I'm not overly prescribing it or saying I'm a big fan of this. And of course, there are medications. We have all different kinds of medications to help with pain. There are simple items like acetaminophen or Tylenol. You can get that at any pharmacy. You don't need a prescription. You can also get anti-inflammatory pills. Some of the brand names you might see out there are like aspirin, ibuprofen, Aleve, and you might have seen commercials on TV about that. And then we do have other medications available by prescription. That can include anti-inflammatory pills, or some of those heavy-duty painkillers like oxycodone or brand name Percocet, hydrocodone or Norco. Those are those really heavy-duty ones, and you don't want to get hooked on that stuff if you can help it. There are also other things that we call medications, but they're really food supplements. You might have heard of them like glucosamine, chondroitin, and MSM. Those things are actually components already of your cartilage, and do they actually work? I'm not sure. There are some studies that say yes, they work. Other studies say no. They are harmless. They do not interfere with any medications that you're on. So what I usually tell patients, if you want to take them, the only thing you really have to lose is the money that you spend on them. And I have some patients who swear by them, others say it didn't work. So if you wanted to try it, go for it. We do have another option of injections, basically sticking a needle into the knee and putting in medication. One of the simplest ones is cortisone. And it's actually relatively cheap. I think it's like $10 or something. That's, what we end up charging the insurance. It does take about a week to kick in. It's not super fast, and so you'll probably notice relief in about a week or so. And in some people, it doesn't work at all. By the time you get like really bad bone-on-bone arthritis, it may not give you that much relief. Some people are doing these other types of injections. They're called gel injections, and the long name for it is hyaluronic acid, and that's quite a mouthful, or we just call them HA injections. It's actually made of the same fluid that's already in your knee, but in a really, really concentrated form. It's kind of like a lubricant. It's like putting oil on a squeaky door hinge or something. Does it work? Again, maybe about a 50-50 chance that it's going to help, and it is considerably more expensive. I think the cash pay price can vary between like $500 and $800 per injection. And again, if you have a 50-50 chance, I'm not sure if you want to spend the money. It is approved by many insurance plans, so you'd have to check with the individual insurance plan and your physician if you wanted to try that. And you might have also heard of stem cells. These are not that widely used. Insurance carriers are not approving them as of yet, and the cost can vary between $1,500 and $5,000. So do they work? Not sure. We do have some studies that are very promising, but I usually tell patients, if you have $5,000 to spare, why don't you take a nice trip to Hawaii? That will do you a world of good. But if somebody really wants to try it, we are more than happy to provide that service. And I know in our office, we do look around for companies who are willing to do it at a cheaper price, yet gives the highest quality product. So we really do work with them to try and help our patients. So if none of the above has worked, is it time for surgery? How do you know when it's time for surgery? Just don't ask me how, but patients just know. They will wake up one day and just realize they are ready for surgery. We never actually try to talk somebody into surgery. I mean, this is elective surgery. It's big time surgery. It has risks. So if and when you're ready for surgery, you will just know it. I do find that by the time a patient is actually ready for surgery, they've already gotten to the point where the knee pain is limiting from activities. They can't go out as much. They just can't do the things that they want to do. They're waking up at night. They're thinking every time, oh, great, I have to get up and walk. How much? It's just really grinding on them. If you talk to their family members, it's just very frustrating. They're in pain all the time and just miserable. And they've already tried everything else that we've talked about to really try and get better. Does that kind of make sense? So now, if you come to the point where you need surgery, what can you actually do? There is an operation called arthroscopy. It's where you look inside the knee with a little camera and try and scrape the cartilage. This actually used to be done many years ago. I remember when I was in training as a resident, we would do an arthroscopy on everybody with arthritis. Then studies did come out that showed it does not work and actually does make your arthritis worse. So if you are just having arthroscopy for the arthritis, it's not going to end up working. Therefore, we don't actually do this just for arthritis. We do arthroscopy for other reasons, like if you have cartilage, meniscus tears, but not just for arthritis. The best operation for really bad arthritis in the knee is knee replacement, and there are two kinds. You can have a partial knee replacement where you're only replacing one half of the knee, or you can have a total knee replacement where you're replacing all of the bone surface of the knee. And how do you know which one to do? Should you do partial or should you do a total knee? Well, a partial knee replacement has a lot of advantages. It has a smaller incision, so it's going to be less pain. You do have a bit of a quicker recovery. We'll end up having better movement. And your knee kind of feels more normal because really, this half of the knee is good. Still have all your ligaments. So overall, it is a much quicker kind of a recovery. And about 8% of knee replacements in the US are partial knee replacements, but this is a much more technically challenging procedure. And you're thinking, well, wait a minute, you're only replacing half the knee. Why is it harder? It is. It's a tougher operation. It's much more difficult for us as a surgeon to get the implant positioning exactly right. And not everybody is a candidate. I mean, it looks like a nice operation, but we have to pick and choose the patients very carefully. We have to absolutely make sure that there is no arthritis on this half of the knee. If there is arthritis in this half of the knee, this partial knee replacement is doomed to failure. If this ligament way deep down in the center of the knee is gone, again, the operation is doomed to failure. It just won't work. And if your knee is like really, really crooked, a partial knee replacement is not going to be able to correct that. So it really is up to the surgeon to very carefully examine the patient and then give you the best advice as to whether or not you are a candidate for that procedure. So if you're not a candidate for a partial knee replacement, then you could be a candidate for a total knee replacement. And there are about 600,000 of these done every year in the United States, and within the next 10 to 12 years, we're going to have about 3 million joint replacements being done. That's a huge number. So we're going to need more doctors, nurses, and surgery centers to handle this volume. And this is a great operation. We have 90 to 95% great results in terms of a dramatic reduction of knee pain and really a significant improvement in the ability to perform your regular activities, walking, going up and down stairs, just getting out and back to your regular life. But there are limitations, as with anything. So, we do know that within the first 2 years of having this procedure, we do end up having to revise them, meaning either the knee replacement has become loose, or it's wobbly, or maybe it just wasn't put in quite 100% straight. So we want to really do everything that we can to eliminate these repeat or redo operations. And now that's where this exciting technology actually comes in, and that can help improve your chances of having a very successful operation. So if you're going to have surgery, I would really recommend considering the outpatient surgery center. They actually invested in this technology to give your knee replacement the best chance that it will end up lasting a lifetime. And we'll talk about the actual technology in just a few minutes. And the surgery center, they will roll out the red carpet for you and treat you like a VIP. You actually get assigned your own personal joint coordinator. You get a one-on-one education class right before the surgery. You'll get a lot of material, written material, so that you can really educate yourselves about what is about to happen to you. They will offer you a tour, so it becomes a much more familiar place, and you just get everything is just so planned well in advance. Things after surgery like rehabilitation and physical therapy are arranged. Your pain medication, pain management is second to none. And to be honest, knee replacements are one of the most painful operations that you could have, way more painful than hip replacements. So it's up to the doctors and nurses to get your pain management under control right from the get-go. That's where actually the surgery center does a phenomenal job. And they'll also kind of check with you to see, well, what are you going to need at home? Do you need a walker? What other things are you going to need? We just want to make sure that you're safe before you go home and have everything arranged for you. And at this outpatient surgery center in La Jolla, which I'm very proud to be affiliated with, they are amazing. They're way less expensive. So, you know, this era of cost cutting, insurance plans, high deductibles, this is a really, really big factor. They have a much less chance of infection. I don't think they've actually had any infections at all in doing over 1,200 joint replacements. And the best thing is you get to recover at home. You get to go home after the joint replacement. Now, I just want to talk to you about that breakthrough technology. It uses computer and robotic assistance. It's called the Navio. And the best part, it's available at no additional charge at the Outpatient Surgery Center in La Jolla. You know, the Outpatient Surgery Center, they've been doing joint replacements for over 10 years. They're very, very experienced at it. And they decided that it's worth it to invest the time and money into this robotic technology to help patients get a much better outcome. You know, we already had great results, like 95%. We want to get as close to 100% as possible, and that's where robotic assistance is going to help us to go from good to great. And right now, robotics are used in joint replacement probably about 15 to 20% of the time. So it is starting to increase as surgeons are becoming more familiar with it. And it is available for both partial and total knee replacements. So what exactly is this whole robotic thing about? Well, you know when you take your car in to get your tires balanced, the technician does this fancy thing, hooks your car up to like this computer gizmo and looks at it and sees if your tires are out of balance. If they're out of balance, they're going to wear out on one spot and they're not going to wear out on the other spot. So similarly, in a knee replacement, if you look at this x-ray over here, this one you can see is kind of off kilter, it's kind of at an angle. It's not aligned very straight, so it's going to wear out much faster on one side versus the other. Whereas this one, it was put in perfectly straight, perfectly aligned. It will have a much, much less chance of wearing out prematurely. And I do have an example of this. This is what we use to actually do the joint replacement. This is a burr which basically removes the bone, the bad bone that you have, the arthritic bone, and the computerized robotic guidance system does not allow me to remove more bone than what needs to be done. And we also do this at a very correct angle. This is what this computer screen would be. This is what we see during surgery. The computer has mapped out where I need to remove the bone, and I kind of follow it along like a video game. And if I am kind of going off by like half a millimeter, this machine just stops and it will not let me proceed any further. And so the accuracy of the implant positioning matters. And you can see over here, this thing is off at an angle. It is not aligned with this other piece. So these are some examples. This one is tilted kind of way down too much. This piece should be kind of more straight up and down, like horizontal. So these are just some examples where things were not put in quite straight. Now these x-rays are of partial knee replacements that were done with the robot. And these are all nice and straight. And you can see how this one here, these are all nice and horizontal, exactly where they should be. I just wanted to share a story with you. These are the x-rays of one of my patients. You can see here, he's kind of bone on bone. He's got bone spurs over here. He's a very pleasant 58-year-old gentleman, and he was a bit heavier as well. And he came in for a joint replacement. I was a total skeptic on this robotic technology. And so we ended up going ahead and doing the joint replacement with robotic technology. And I'll admit, it took longer than the way I normally do a total knee replacement. I was really skeptical. I thought, wow, I can do a regular knee replacement maybe in an hour, hour and a half, and we get pretty good results. I'm usually happy with my x-rays. And this took a bit longer, maybe about half an hour to 45 minutes longer. His x-rays turned out to be beautiful. We're very, very happy with that. Okay, so that's all well and good. The best part is he came back at 10 days after surgery. He was not taking any pain medications. I was absolutely stunned. I'm thinking, well, I'm the same surgeon. I'm putting the same implant in. I'm doing things basically the same way. The only thing that was different was that I used the robot. What is it that the robot offered me that doesn't offer other patients? And I think that half degree more of precision, maybe that 1 millimeter more of perfection was enough to make this patient feel like, wow, my knee replacement actually works out very, very well. He's off his pain medications at 10 days. He came back at 6 weeks. I couldn't recognize him. He had lost 20 pounds. He was back exercising. As I said, he looked younger. Oh my goodness, he looked absolutely amazing. And he was very happy. He was walking back to his regular life. So he had a very good result. And I thought, wow, the robot actually does work. So that's the end of our formal presentation for those of you who are watching online. And thank you so much for listening.